All right, why don't we start? Talking to Ed earlier, my name is Sanjay Mehrotra, by the way. I'd like to introduce Ed Kaplan. Talking to him before, within Informs, I would say Ed couldn't be more distinguished and as a contributor to the community, as a community member who I could have found to actually be our speaker for this very new webinar series. I think it's going to take me like 10, 15 minutes to to really read all the accomplishments that Ed has had. But I'm going to just be quick, just a couple sentences. As being a president of Informs, that's an achievement of in its own. Ed's been an AE member and Institute of Medicine member. That's rare. You'll find typically an AE members in engineering school, but somebody actually who can traverse both grounds and get that kind of achievement is incredible. And Ed has won just about all the major Informs or related awards where OR is applied. His work very, very early on, many years ago, was in needle exchange when HIV had just hit the street, so to speak, as a major problem. And of all these years, I know that Ed's really worked on contemporary topics, something of truly national importance, and something that needs operations research to find deeper understanding and better solutions to the problem. So with Ed, I think what he was saying before, I'm going to repeat, believes in simplicity, in simple models, but simple models that actually have the depth and go a long way making difference on the ground. So I think with that philosophy, to which I totally subscribe, Ed, the floor is all yours. He's going to be talking about all his contributions through Yale on how he has helped the community with dealing with COVID. Ed, please.
Well,
thank you.
Thank you very, very much. I greatly appreciate the invitation, and good afternoon to all of you, although it could be good morning, it could be good night. I don't know where everyone is. Let me just share my screen here, and hopefully people will now see what looks like a covered slide from a PowerPoint presentation. Can I just get a thumbs up to see if you're actually seeing it okay? Sanjay, you can see the...
Yeah, I can see it well.
Okay, so now you can hopefully see the whole thing in full screen mode, and off we go. So I'm going to tell you a little story here about how I got involved in COVID work and what happened during the first year of the outbreak. And before I do anything else, I have a confession to make. And the confession is that about a year ago, we were sort of coming to the end of the summer of 2020. I might have even thought that I know something about this problem. I was pretty much up on the literature. I was sort of following what was going on around the world. And as of 1 year later, it's not immediately clear to me that I'm much of an expert in anything anymore. The data change every day. The interpretations of the data change every day. Things about the disease itself that weren't really expected suddenly poke their heads through, things like the ability of someone who had been previously infected and recovered to be reinfected, things like the waning immunity of vaccination, things like vaccination itself, which of course weren't around when this whole crisis first broke. So it's by no means a finished story here. Most of what I'm going to be talking about is work that took place last year. Starting right when the outbreak started in my part of the country, which would have been at the beginning of March of 2020. And what I'm going to talk about are so-called scratch models. These are very simple models which are built very, very quickly. If you want to think of having a client here, I was really working on behalf of the university more than anything else to try and help the university make decisions. It expanded, it included the hospital, it included the state of Connecticut later, but most of the action happened with the university in mind, and it happened very quickly. And so let's just get started. This is what our committee looked like. We had our first meeting on the 3rd of March. Oh, I should just say one other thing. I ended up on this committee because my arm was twisted. I was meant Sanjay before we started today. I actually hadn't been doing that much work in infectious diseases or public health really for about the past 10 years or so. The last time I was really involved in serious projects had to do with bioterrorism concerns, work with Larry Wine, and also a little bit of work still in HIV, mainly having to do with trying to put together an HIV incident surveillance system at the Centers for Disease Control. But that work is well over 10 years old. And so I hadn't been in this area for a while. I was focusing on other things. But this broke, and Albert Coe, you see his name third listed down on the right here, the chair of the epidemiology of microbial diseases department at the School of Public Health, basically said, you have to be on this committee. And so I agreed, and you can see that I'm the only OR person on it. This committee initially was chaired by the director of Yale Health, which is our local health plan, but it included 3 deans of medicine, nursing, and the School of Public Health. And it included epidemiologists and experts in infectious diseases and experts in infectious disease control at the hospital. That's who Rick Martinello was, and clinical people, and then also very senior level. We had the chief of staff for the university president. We had the director of the New Haven Health Department, the city which hosts our university, vice provost for health. So it was a committee that was really loaded with people who knew a lot more about epidemiology than I do, and with people who were heavily involved in making decisions at the university. But nonetheless, I find myself on this committee. And we were basically given a task of advising the president of the university on anything that had to do with COVID-19. And he didn't, it wasn't even clear what all the issues were when we were just getting started. And we met every day by Zoom at 7 a.m. Day after day after day. Those meetings subsided somewhat over time. Now they happen 3 times a week instead of every day. But at the beginning, it was every day, and including the weekends, by the way. So it was rather intense. So here's the kinds of issues that we addressed. And by the way, I don't mean to suggest that there's necessarily something pathbreaking about this. Many other universities went through the same process, and they relied on their own in-house expertise, researchers who they know inside the university who could help. In some places, operations researchers actually have been incredibly important. At Cornell, for example, I know that people like Pete Frazier and David Schmoys and Shane Henderson and others have been heavily involved in advising Cornell what to do. The University of Illinois, there's a professor in the physics department who's been very involved. So depending upon where you were, different people have helped out in different ways. But here are the issues that we faced right at the beginning, and most of these, I would think, are common across all of our residential universities in this country, and indeed in many universities around the world. So infection controls, is the social distancing, travel recommendations, those were some of the first things which had to happen. Are we going to shut down? When do we shut down? What's the largest crowd sizes should we allow? What kind of symptom monitoring or health checks do we have? What should we do about student housing? Are we going to keep the students on campus? Are we going to tell everybody to go home? We're going to switch to virtual as opposed to in-person education. These are all questions where the decisions were made pretty quickly, but the point is that they wanted to have some analysis to support this decision-making process rather than just sort of guess the answer and run with it. And so that's where some of the work that I was involved in really sort of came to the fore. Screening of students when the students come back to the university. So-called gateway protocols, which again, I think are common to most of the university students come back. There's that initial test or two, sometimes required by state law to determine whether or not a person newly entering the community is possibly infected, and to quarantine or isolate them if they are. But then also during the year, we have a repeat asymptomatic testing program. Some universities have comparable programs. Not all universities do. These are very expensive. If you have thousands of students and you're going to be testing them twice a week, that's a lot of tests. But basically, why test twice a week? Well, that's one of the things we'll talk about when we get to that part of the talk. Something that was perhaps a little more unique here has to do with the testing of sewage sludge or wastewater for SARS-CoV-2 RNA as a way of monitoring the local outbreak. And I'll have more to say about that. And then actually, you'll remember at the very beginning of COVID, nobody really could test easily because there was a real shortage of test kits, and almost all of the tests were reserved for people who already had symptoms, or perhaps for people who had contact with people who were really sick. And in fact, at the Underhaven Hospital, many people would only get their COVID test after they had already been admitted to the ICU. The key question there was whether someone needed a negative pressure environment if in fact they had coronavirus, as opposed to a non-infection controlled ICU bed if they didn't. Anyway, so these are a lot of the different issues which this committee worked with. And so what I want to do is emphasize on how modeling helped to support local decisions. I'm not going to claim that the models did everything here, that basically people were waiting for the result of some formula to decide what to do. It was much more in the guise of saying this was one among several different ways of providing advice. So the one thing about the models is that a lot of them were developed incredibly quickly. Very simple models, things that you could, give as an in-class homework assignment. In-class homework, that's contradictory. You know what I mean? An in-class example to your students. It would take them 10 seconds to figure out. But nonetheless, for people who are not in our field, it's not as obvious. These modeling requests from the university, as I said, expanded to the hospital, and at least at the very beginning, to the state of Connecticut, where the key question was, how much is the state in danger of running out of ICU beds for COVID patients? That was the critical concern. Was there going to be a possibility that the hospitals would be overrun? And this relates to that whole flattening the curve discussion that I'm sure everybody remembers hearing about during the first couple of months of the outbreak. So I'm going to give you some examples. I'm not going to talk about everything here. I'm going to give you some examples, and I'm going to talk more about what the approach was, what the problem was, and what the related decisions were, and try and put everything kind of in the context in which this happened. And I won't really get that much into the math, except in one instance, I'm going to sort of show you a little bit more of what's under the hood, just because I think it's probably more interesting and maybe a little less common than some of the other stuff. So let's get started. We'll go back. Remember, I told you this committee had its first meeting on March 3rd. On March 7th, 4 days later, everyone in the Yale community received the following email, which basically said, here's new information about the response to coronavirus and prevent transmission of the virus. We're asking students, faculty, staff to postpone, cancel, adjust all Yale-hosted events other than classes that will have 100 or more participants. And they said that this recommendation applies to events taking place between March 9th and April 15th. This email went out on March the 7th, okay? So, and the committee's first meeting was March the 3rd, 4 days, okay? So what happened in the 4 days? Well, everybody knew they wanted to limit the size of events because everybody understood that it was possible for this infection to be transmitted. The question was, by how much? And so we framed this in a very simple way, which is that the public health goal for any event is that there shouldn't be any new infections as a result of the event. That's basically the statement. And so we presume that the event is taking place in a sterile location, because of course the decisions had already been made that all possible meeting spaces, classrooms, hockey rinks, basketball courts, you name it, all places where people were still coming together, were all being wiped down, were all being disinfected. So you're going to get no new infections at a sterile location in two different ways. One, nobody is infected, no one who joins the event is infected, in which case if no infections come in, you can't create new infections out of nothing. And the second one is that at least one infected joins, but there's no transmission as a result. All right, so those are sort of the two ways to think about there not being any infection. Now, a lot of people worried mainly about the second question, which has to do, of course, with, well, so we want to make sure that people are spaced a certain distance apart. We want to make sure everyone's wearing masks. We want to do all of the things that would basically reduce the chance of transmission in the event that there are infected people in the room. But the one thing I pointed out was that the probability no infections occur is going to be at least as large as the probability there are no infected persons joining the event, right? And consequently, you can go a long way by limiting the event size, because that's basically how you can control the likelihood that no infected people join the event. The committee adopted a criterion. It's named after, again, that same Albert Coe who twisted my arm. And so it was called the Coe criterion, which is that there should be a 99% probability of no new infections. And so you basically can control that by capping the crowd at whatever, less than 1% divided by whatever the prevalence of infection is. That's very back of the envelope. Now, all of you know how to deal with coin flipping or Bernoulli processes or whatnot. But when we're talking about probabilities of infection that are that low, basically everything just linearizes. So pretty simple chart. You tell me what the prevalence is. If it's 1 in 100,000, then you don't want to have more than 1,000 people in the room. If it's 1 in 20,000, you don't want to have more than 200 people. If it's 1 in 1,000, you don't want to have more than 10. And so now the question is, all right, this is great, but what's the prevalence? And of course, nobody knew because this discussion is happening, March 2nd and 3rd. The very first case in the New Haven local commuting area, if you want to think about that, happened in Westchester, New York, and that was reported on March the 3rd. There have been cases in New York earlier, but they were all cases that involved imported infections from the outside. They were all travel cases. Someone had gone out of the country and came back infected. Those were known about. What was special about the Westchester case was that there was no such history. This was someone who had been uninfected and had been running around New York visiting lots of different people and suddenly found himself infected. And so the question was, well, how did that happen? It means that there must be some community transmission going on. That was the idea. In Connecticut, it took another 4 days until we got our first instance of community transmission. All right, so what's the prevalence? Well, in some ways, it doesn't really matter. What matters is how large a prevalence you want to defend against is. I want to cap crowds to defend against some prevalence. And this is a little bit of a Homeland Security mindset. You're trying to harden a target in some ways. People felt comfortable with 1 in 10,000. And the reason for that is, first of all, at the time, there were no Connecticut cases. And people were thinking about, all right, how many people could really be infected in the area? And we're not seeing any cases. And people felt that 1 in 10,000 was sort of a reasonable number. Now you could go through and figure out the probability that you're wrong and all that sort of stuff. But remember, this is all happening very, very fast. 1 in 10,000 was the number people agreed to. I didn't advocate for that, by the way. I just let the discussion go as it went. And that's why the crowds ended up being capped at 100. If you allow 10,000 people, if you have a 1 in 10,000 infection rate, then capping crowds at 100 will give you a probability of no infections of at least 99%, just by virtue of the fact that the probability that nobody enters is going to be that high. All right, that was on March 7th. 9 days later, on March 16th, this all became moot because new guidelines came out from the federal government, and the new nationwide guidelines called on all Americans to avoid gatherings of more than 10 people. At the minute this was announced, new Yale announcement, there will be no events with more than 10 people. So there's a case where he had a little bit of a back of the envelope analysis. It took like 20, 30 minutes to try and explain this to people. They basically said we're going to limit events to most 100 people. By the way, it was controversial at the time. Yale isn't good in all that many sports, but one thing they're good at is hockey, and the hockey playoffs were happening right around then. So basically we were telling people they couldn't go to hockey games. Anyway, shortly thereafter, when this came out, everything just quickly started to shut down. Okay, now I'm presenting these as sort of sequential examples, but the fact is a lot of things were happening at the same time. So also on March 7th, all right, remember March 7th was when that first email went out, but the following article came out from an Italian newspaper. This is a translated version of it, that it was shared with one of our hospital people and brought to our committee. And this was from the coordinator of the hospital system in the Lombardy region of Italy, probably one of, if not the most economically developed part of the country. This is where Milan is. Very modern hospital system, very, very Western. And here's what the person was saying, the director was saying, on March 26th, there'll be 18,000 sick people and 3,000 are going to need respiratory assistance. And effectively, they ran out of ICU beds. And you had people who essentially needed to be in an ICU bed, resting on gurneys in the corridors of the emergency room. And this, of course, made everyone very, very nervous, because you can guess what the next question was, which was, could something like that happen here? Is it possible that the Yale New Haven Hospital could suddenly see COVID patients lying in the halls? So literally upon hearing that report, I proposed the idea of what I call a stress test. And why I used the word stress test was just possibly because stress testing had been, in the financial arena for a while. People were talking about the banks and everything. I said, oh, we'll call it a stress test. Basically, what we want to do is figure out what is the existing ICU capacity at the Yale New Haven Hospital. We want to focus on negative pressure ICU, but I'll start with everything. And then the question is, rather than trying to forecast how many COVID cases you would expect to actually see, you turn the question on its head and say, what's the largest arrival rate you could have over any extended period of time and not have significant bed blocking? Or, because this is what would happen, and people wouldn't be able to get into the ICUs. So, what's the largest rate you could have? And then you ask the question, okay, whatever that rate turns out to be, do we think that things could be worse than that? If things could be worse than that, then you're going to surely be out of beds and in trouble. So that was the idea here, to take the normal focus on capacity and kind of turn it on its head. You say, I give you the capacity, you tell me what the largest arrival rate can be in some sense, so that you won't get a lot of black. So we got baseline data on the existing bed occupancy in the ICUs. This is even before COVID, 90% of the beds were filled. Just starting there, okay? So your base utilization or your base occupancy of your resources is already at 90%. And at the time, no one already, people didn't know what the length of stay in an ICU bed was going to be for someone who had COVID. People thought that it could be, 3 to 10 days or whatnot. The idea that someone could actually be in an ICU for, on a ventilator for a much longer period of time. And, people just didn't know. But so this was the range that we were given to work with. And so, as I said, rather than try and predict how many cases there would be, we turned the problem on its head and say, what arrival rates, and you think of these as reflecting peak periods, what's the largest arrival rates they could be handled? So that was the idea. Now I'm being a little bit full of myself to put this paper up. But anyway, queuing models have often been used to study ICUs. And so we did, again, very, very simple. We didn't try to do something fancy where we take into account, COVID, non-COVID, model it in any kind of an extended space-based ways. We basically just modified our long loss models to account for 2 different patient types. That's all we did. Really quite simple to do. And so here we are. We started doing this, I think I said, on March 7th. So findings were delivered 3 days later. So if a single COVID ICU patient would arrive per day, 1 per day on average, the existing MICU, that's the medical ICU capacity alone, there are 25 negative pressure beds. That's not sufficient to prevent blocking 30 to 40% of the COVID patients. That's sort of the thing you would see. So right away, it's like, okay, we obviously need more than the MICU. You took a look at all the negative pressure beds in the hospital, negative pressure ICU beds, of which there were 57. Well, now what would happen is you could handle, if there was 1 per day, you wouldn't be able to handle it if there were 5 per day. Oh, now I should say something about the scale of the problem, so you know if 1 or 5 is a big number or a little number. New Haven itself is a pretty small city. It's only like about 129,000 people or something. The immediate region served by the sewage treatment plant is about 200,000. The metropolitan area is closer to 500,000, but the El Nuevo Hospital is the largest hospital in the state. And it actually brings in people from all over the place. And so now you're really talking about a potential patient, drawing population from which the patients come is in the low millions. So thinking that you would get away with only one arrival a day seems pretty Pollyannish. Even 5 arrivals a day might not be great. If you had 5 arrivals per day, the 57 negative pressure ICUs was not going to work. So we made it very clear that in our view, there had to be more capacity. Well, it turns out that part of the hospital is a cancer hospital, the spinal cancer hospital. And when that hospital was built, the top 3 floors of the hospital had been engineered in such a way that in an emergency, they could convert what were normally just inpatient beds to negative pressure units. The negative pressure capability was already built in. So basically we said, look, let's give us your best, give us your max. 3 floors of that hospital would give you 84 negative pressure ICU beds, which means that all those cancer patients had to be moved out of the cancer hospital. So where did they go? They weren't sent out of the hospital. They had to go elsewhere in the hospital, which meant that there were different patients who were displaced. And as happened in hospitals all over the country and around the world, the overall level of severity to sort of be admitted to the hospital just went up. And elective procedures were deferred. And so this is a pretty common story. This got us up to about 13 or so COVID ICU arrivals per day without serious bed blocking and boarding issues. And that we felt was actually large enough. If you think of what 13 per day over a period of many days would give you in our population, again, that actually would add up to a lot, given what we know about of all new infections, what fraction are sufficiently serious that you could actually end up in the ICU. So those preparations actually saved the ICU from overflowing. What happened was during the worst of the first outbreak, so I'm talking about during March and April of last year, all of these beds filled up. It was like watching water in a bathtub come right up to the edge, but actually no patients were blocked. We managed to just get away with it. So in that sense, we were lucky, but it was this back of the envelope modeling at the beginning that basically was decisive in saying, you know what, you really need to do this. And you can imagine from the hospital's point of view, moving out a whole bunch of cancer patients and reconfiguring the floors was a very, very big deal. Okay. I'm going to give you a different application, and it has to do with trying to figure out what the actual size of the outbreak is. And so here's the idea. If you remember at the beginning of this outbreak, testing was a huge problem. First of all, the CDC had messed up with the original test kits. You'll all remember that story. And there were not nearly enough tests available to do what you might call surveillance testing to try and just figure out what, in some sense, is the actual level of infection in a community. In fact, almost all of the tests were being used on people who were symptomatic or people who were really, really sick. As I mentioned before, some people admitted to the ICU didn't get a COVID test until they were already in the hospital, all right? So instead of testing giving you an indication of how many people were infected in the region, it was really that the most seriously infected people were driving the testing. That's what was happening. So there's this question as to, well, how bad is it really? I mean, we obviously things must be getting worse. You see people getting sick. We had no idea whether we were talking about, 1%, 5%, what percent of the community do we think is infected? So it turns out that Professor Jordan Peccia, who's in our environmental engineering group, is a world expert on doing things like figuring out what kinds of viruses and bacteria are on the surfaces of desks in schools would be one example. Or looking for different pathogens in wastewater is another thing that he has a lot of experience with. And so it took from March 6th until March 11th for me to figure out that he's the person I had to talk to, but we found each other. And that led to a meeting on March 16th with other researchers who could contribute in some way to a proposed analysis, which was going to study the COVID outbreak from some kind of environmental monitoring. The original idea actually was to go to the New Haven train station. For anyone who's been through here, that's the train which goes back and forth to New York on the hour. And so that's typically how we imagine that would be the most likely way that infections would be getting introduced. And so that if we could somehow or another get a constant monitoring based on effluent from the train station, that might tell us something. But actually, Jordan thought that was a very bad idea. It has to do with how one actually is going to sample. And it turns out that trying to sort of focus on that kind of flow capture is much more difficult. His suggestion was go to the sewage treatment plant. And then you think about it, say, the sewage treatment plant, a wastewater collection network is like a tree network. Everything flows in, and by the time it's actually in the plant, we're talking about highly, highly concentrated sludge. And it's possible to then take samples directly from that sludge and basically get a daily, albeit extremely noisy, sample representing a community of roughly 200,000 people. And that was the idea. Okay, so we agreed to focus on the local wastewater treatment plant, and the director of that plant agreed on very short notice to do that. And the first samples were being collected on March 19th. March 6th to March 19th, less than 2 weeks, we went from the original idea to actually having implemented it. Who got to have the honor of collecting these samples of sludge? Well, this is why God created graduate students. So they were the unlucky people who had to go in and actually do the sample collection. As you can imagine, this is not fun stuff to work with. The daily sampling actually continues to date, and it's been expanded to other treatment plants around Connecticut. And I'll show you what we learned from this. But first of all, operations people, you might be interested in the kind of operation we're talking about here. So here's an aerial view of this plant. 40 million gallons per day go flowing through this thing at the max. Serves 4 different towns in the New Haven area. As I said, it's about a population of 200,000. 50 milliliter samples, there it is, just this little, it's if you own dogs and walk them, it's basically as if you're cleaning up after your dog. That's about how much you're getting here in daily samples. And what you're testing for is the concentration of SARS-CoV-2 RNA in the sewage sludge. That's what you're looking for. And here's the picture. And this is just a raw data with a very simple smooth, starting again from when we started in March through a year ago, August 12th. And boy, oh boy, I mean, you certainly do see what looks like an outbreak here. There's a lot of noise. You can see these bars are going up and down. And that has to do with the fact that we're taking a very small sample, right? Take a very small sample, and then you quantitate this RNA using something called polymerase chain reaction. So there's a lot of noise in basically amplifying the whole thing up. But nonetheless, we got this picture. Now, what's different between this and testing is that this, in some sense, is a constant sampling process. Everybody is essentially contributing to the sludge all the time and at more or less the same rate. So it's just one of these things where we get a much better view of the timing and also the intensity of this outbreak. Okay, so just the fact that we were able to do that, just the fact that we were able to not only see the RNA in the wastewater, but actually statistically estimate that it would give you a little bit of a lead time into, say, increases in cases or increases in hospitalizations and things like that, attracted a lot of attention. But there's more that you can do with these data. It's one thing to just say what's the qualitative shape of the outbreak. It's another thing to say how many people are actually being infected. What's the actual epidemic that's causing the signal in the wastewater. So here I'm just going to show you a little bit of the modeling. And again, this is a very simple model. But let's pretend that we know the incidence of infection. That's new infections per person per unit time. I say expected number of new infections per person per unit time, because really everything is random. Although, as you'll see, I'm going to give you what looks like a deterministic model, but I'm going to interpret it probabilistically. That turns out to be a very good trick in analyzing these kinds of models, because sometimes you can get to answers much faster than if you run back to differential equations and sort of try to solve everything. Anyway, so suppose we know the incidence. Suppose we know what the incidence of infection is. And now suppose we are faced with what we call a lagging indicator of infection. I'm going to denote that by Y of T. And by a lagging indicator, I might mean cases, I might mean deaths, I might mean hospitalizations, I might mean even the concentration of RNA in sewage sludge. So these are all these examples of lagging indicators. They lag at some random duration from the infection. So what this means is that some time passes from when a person would be infected until you would see the indicator. And so the very first model is simply to say this model, what I call the model scale indicator, is nothing more than the inspected value of the incidence lagged this random time into the past, where Ly, which is the indicator lag, is going to be different for different indicators. So, if we're talking about deaths, when we see deaths moving up and down, they're reflecting infections that happened a longer time ago than if we're talking about people admitted to the hospital, than if we're talking about people who are testing positive, for example. All right. So I'm going to dispense with the integration and just focus on writing these expected values this way, because it turns out that it's really easy to sort of interpret what's going on if you just sort of focus on this lag representation. So we call these things model scale indicators, and all they do is shift the incidence by a random lag. That's all it is. All right. So, what we see in the indicator is basically infections that happened Ly time units ago, but Ly is random, so you have to smooth it out. All right. So the probability distribution for these things all came from the literature, because after all, this is all happening again. We're back in March of last year. And so basically, all we have to go by is what we could find from other people reporting. So again, this is the interpretation. This model scale indicator, it reflects infections that happened Ly time units ago. All right, so let's take a look at two different model scale indicators. One of them is going to be hospital admissions. There had already, by the time we were doing this, been some studies, the best one of which came out from a group at UC Berkeley, where the question was, from the time a person is infected, how long does it take until they're admitted to the hospital? Now, of course, most people who get infected don't get admitted to the hospital. I understand that. But for those who do, how long does it take? All right, that's the question. We'll show you how to handle the fact that most people don't get admitted in just a moment. All right, so those estimates typically were made by first focusing on what's called the incubation time, which is the time from infection until symptoms, and then on the time from experiencing symptoms until hospitalization. Very few people would end up in the hospital without having had symptoms. I mean, after all, what's the reason for going to the hospital? You have to be sick in some way. So the published lag density for this time until hospital admissions was just shy of 2 weeks, with a 95% probability interval going from like 5 to 28 days. Very similar, by the way, to a pandemic planning scenario that the Centers for Disease Control had already posted on their website, where if you're interested in COVID modeling, the CDC, and there are some other groups too, MIDAS is another group. MIDAS is an infectious disease modeling group funded by the National Institutes of Health, and they have pages where they've tried to put together inventories of different parameter values for all sorts of things that you might be interested in trying to conduct trying to create COVID models. All right, so the model scale hospital admissions then is just going to be represented this way. We have our indicator, and it's just the expected incidence LH time units ago, where LH has this mean of 35 days and this 95% coverage interval. We basically use a gamma distribution to parameterize that. Okay, so that's the basic idea. Hospital admissions today reflect infections that were on average happened 2 weeks ago. And then we can do the same thing with the sludge. Now, the interpretation is a little trickier. You have to start asking yourself, all right, if I see a certain RNA, I see an RNA molecule, when did that RNA molecule get excreted into the sewage system? But basically, it's the same idea. And without getting into too much detail here on where the timing information comes from, we use this thing called the generation time, the time from when a person's infected until they infect somebody else. And that in the literature, again, the first estimates had a mean of just under 9 days, a standard deviation of about 4. And so once again, we have what we call a model scale indicator that's just telling you what's the time lag in infection. So the sludge is relating infections that happened more recently. The hospitalizations are telling you infections that happened a longer period of time ago. Okay, so if I just draw a picture, this is what it looks like. If this was the actual incidence of infection, by the way, I haven't told you how I found it yet. I just said, suppose you know what it is. So if you know the actual incidence of infection, which is a solid curve, then basically the viral load in the sludge at the model scale would look like this. In other words, I'm just taking this thing and lagging it by the indicator lag for the RNA. And here's what the hospitalization the hospital admissions would look like. I'm lagging it by the hospital admissions distribution. Okay, so what are the real data? If not everybody who's infected goes to the hospital, and of course, there's going to be a complicated scaling from infections to the observed amount of coronavirus, where the actual units of measurement is number of copies of RNA per millimeter of sewage sludge. So it's kind of a complicated unit conversion going from infections to that. So in the second model, we simply assume that the actual data you observe come from scaled versions of what I call the model scale indicators. So basically, the hospital admissions, the actual data, are going to assume to be a Poisson on a given day, but the mean is going to be some constant times whatever the indicator would be for that. So HFT is coming out of this epidemic model. KH has to be estimated from the real data. And the real data are the actual number of hospital admissions with COVID on any given day. And similarly, for the sludge RNA, we assume that it's normally distributed where it has a mean and a variance that are both scaled to the indicator. It turns out that the RNA data are extremely noisy. So you need to do some scaling of the variance and not only of the mean. Okay, so those are things all have to be estimated from data, and we did that using maximum likelihood. As I said, this was done very quickly, so maximum likelihood is something you can do fairly quickly. And so really what we have in the way of data for this part of the project, we had all hospital admissions to the Yale New Haven Hospital, but we focused only on the same 4 towns that were served by the wastewater treatment plant to try and get the scale right. So we didn't want people who were admitted from elsewhere affecting our sense of what the epidemic scale was locally. And similarly, for the sludge RNA, we had daily measurements through March 19th through May 1st. This is not a long time period. So the study, again, is something that was done very, very quickly. All right, so here's the missing thing. I haven't told you where I got the incidence from. All right, so this is where the epidemic modeling comes from. We needed to have an epidemic model to align the indicators. Basically, you need something to establish when do you think the baseline infections happen so that you can look forward. And of course, the way you do that is you build an epidemic model and then use the data to estimate the underlying parameters of that model. And what we use is a renewal model. We call it a renewal model, which is a generalization of things that many of you are familiar with, SIR, SEIR. Many of you might be familiar with renewal epidemic models as well. And here's how they work. It's pretty simple. If you let S be the fraction of the population which is susceptible, okay, people who have not yet been infected, here's how the renewal model works. First of all, the incidence is just taken to be a product of 3 things. It's how many people were susceptible at time t, what is the so-called reproductive number, the basic reproductive number, reproductive rate of infection, and how many infections happened in the past. And so the argument goes something like this. Say, anytime somebody becomes newly infected, if they were totally surrounded by susceptibles, on average, each one of them would infect R0 others. That's what the reproductive number means. But you can't infect people who are already infected. Now, you got to be careful here, because now, of course, it turns out you can have reinfection in reality. But at the time, if someone was actually recently infected, a person couldn't be infected then. And the same thing would hold for someone who's recently vaccinated, by the way. So basically, you just multiply these 3 things together, and that gives you what the incidence is. Now, what about the susceptibles? Well, in the simplest model, the susceptibles are simply depleting with the incidence of infection. These are the equations for an unmitigated outbreak. The local outbreak was not unmitigated. There were all kinds of interventions. So I'll show you how we try to incorporate the effect of that in a moment. But this is sort of the workhorse here. So now what you need in order to make this work is you need 2 more parameters. You need to know what the reproductive number is, and you need to have some measure of an initial condition. How many people were infected as of time 0, which time 0 in this model is going to be sometime in February, actually, that we took as time 0 to work backwards. So we have to estimate R0. We have to estimate an initial value S0, and then we have to estimate these 3 constants, which are the scaling constants. All right. And so when you do that, here's what it looks like. And as I said, the data are very, very noisy. Here's what the actual RNA concentration looks like. Here's what the daily hospital admissions look like. And the dashed line in the middle here is what your estimated infection curve is generating in terms of where these indicators would fall. So the dashed line is actually the expected value of the number of hospital admissions, or the expected value of the sludge, and it's given by taking a constant, which is estimated, multiplied by what I called the model scale indicators, all right? Turns out, remember, this is last year, we ended up with a point estimate of the reproductive number of about 2.4, which is smack in the middle of what everybody thought COVID reproductive numbers were. This is all before variants, all before Delta. So, things are much worse now. But at the time, we got something which made sense from a scientific point of view. And so now there's one thing which should be bothering many of you, which is, but wait a minute. You showed us a model for an unmitigated outbreak, but there were all these things happening. There were lockdown like stay-at-home orders, and they were imposed as early as March 22nd, and there were less restrictive orders that go back to March 10th, like, for example, you shouldn't have gatherings of size 10 or larger. That was a federal order. So how could it possibly be that the model I showed you works? And so the answer is, by itself, it couldn't possibly work. So we have to ask for how we could somehow or another represent all these interventions. Now, in a different paper, which was published in MSOM, I showed different ways that one could look at different kinds of interventions. But at this point, we were doing something, again, very, very quickly. The easiest model that I could think of was what I would call bifurcation. What does bifurcation mean? It basically means that you take the population and you split it into two pieces. Piece number one stays at home and they're safe. And piece number two, essential workers or people who can't protect themselves, like nursing home occupants, they're an exposed population. So the epidemic model only really applies to the exposed population. The people who are stay at home are assumed to be safe. And what you actually can do then with this approach is actually estimate all the parameters. And then the question is there a way to work backwards to figure out what the bifurcation was? What fraction of the population was actually exposed and what fraction of the population was essentially compliant with these stay-at-home measures? And when you do that, you get estimates for the following kinds of things. Of the 200,000 people who live in the area, how many were actually locked down effectively? How many remained exposed? And of those, how many got infected? So it turns out that all of those things are identifiable, and the arguments for that are contained in this second paper, which came out in Healthcare Management Science. It was actually just a little more than a year ago that paper was written up. And here's what the answers are. As I said, you get this estimate of the reproductive number of about 2.4, and you get an interesting analysis that basically says 89% of the population was really more or less protected. And let me tell you, from living here during that time, the place was really locked down. And I don't just mean the university, I mean the whole area. New Haven was a ghost town. And in terms of the percentage of the entire population that got infected, we estimate that the cumulative incidence of COVID as of the end of May last year was at 9.3% of the total population. All right. So things have continued in wastewater land, and I just want to show you how so. So first of all, this graph here is interesting because it shows you not only how many positive tests there were over the entire outbreak to the end of June of 2021. So the gray bars here are actually positive tests. Worded differently, these are COVID cases. The red bar is the actual total number of tests that were being administered on a daily basis. And so you see the difference. Look at how this is, it's noisy to be sure, but look at how this is going up, 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 up. So you were clearly getting a very biased view of the beginning of the outbreak. These cases that you saw were coming from a very small number of tests. If you had tested much, much more at the beginning of the outbreak, you would expect that that first part of the curve would actually be much more intense. Well, now look what happens when we take the wastewater RNA and plot it out over the entire time period. And what I want you to see is that when I take a look at this first wave and the second wave in terms of the wastewater, while it's still the case that the second wave is certainly longer than the first wave is every bit as intense as the second. Whereas when you look at things on the scale of cases, you get this much smaller grouping in the cases at the beginning and much larger towards the end. And essentially, this is just an artifact. This is just an artifact from how testing rates change and also how test targeting changed. I mean, look, all of a sudden, Yale University, which is testing students twice a week, that's that's contributing to these tests here. So I would argue that what you have at the bottom here is a much more unbiased view of the whole outbreak or outbreaks than what you had up at the top. And these are just data. There's no model yet. But it turns out that it's really, really simple to build a model once you have data like that. Because if I just now, I'm going to do something so simple. I'm going to focus on a first order model. If you think back to the whole discussion about the indicator lag, if you just did a first order approximation, what you would be saying is that infections that happen at time t are going to be reflected in the wastewater at time t plus mu f, where mu f is that mean generation lag or that mean indicator lag between infection and when the coronavirus is detectable, or when the RNA is detectable in the wastewater. And from the earlier analysis, we had already estimated a 9.3% cumulative incidence as of May 2nd. So once we have that as a base point, and we have with this very simple first order model, the idea that really you're just seeing a delay, a first order scaling model just looks like this. Cumulative infections up until time t are just going to be 9.3% of cumulative infections in the RNA, so cumulative RNA concentration at t plus mu f divided by whatever the cumulative RNA was at my base time t star plus mu f. Well, time t star, as I said, is May 2nd, 2020. It was the date on which this 9.3% corresponds to. And so now what happens? Well, something interesting happens. First of all, focus on this blue curve here. This blue curve, which is cumulative incidence, is nothing more than this simple formula. All it's doing is saying, take literally the cumulative RNA, which is just found from adding up, basically, you're just adding up these bars over time. That's what the cumulative RNA is. All right, you just add it up and divide it by whatever the cumulative RNA was on May 2nd plus 9 days, multiply by 0.093, and that gives you this blue curve. And now I'm going to compare it to 3 different models. The model which looks closest to what we're saying here, which is this black curve, is a machine learning model, COVID-19 projections. I'll get the name wrong, but basically it was a machine learning model, and it was calibrated only on deaths. This orange curve comes from a published model called COVID-STIM, and it is a model which uses deaths and reported COVID cases, and it tries to mathematically adjust for the lags between infection and tries to do it a little bit on the dynamic side, taking into account how things have changed over the course of the outbreak. And then this third model is also a model that was developed, but now it incorporates things like, measure of mobility and so on. Anyway, the story I'm trying to say here is that all 3 of these models, other than the wastewater, are really quite complicated mathematically. If you take a look at them, they've got tons of equations and tons of compartments and everything else to try and make this work. And here we're just scaling the wastewater, and this is the confidence interval which comes from that wastewater estimate. And you see that sort of keeps the other models right inside the neighborhood. Okay, Sanjay, I'm guessing you're telling me that I don't have much time left. So let me just try. I'll
2 more minutes.
Yeah, I won't really summarize. I'll just sort of tell you what you were going to see and where you can go find it. But the use of the sludge data continues. We're doing this now at several different sewage treatment plants around the state. And in some cases, we detected outbreaks in the sludge before you actually saw them reflected in case data. And so, by the way, so you can see New Haven, things are now starting to get worse again. In the town of Norwich, things went up very, very quickly. These are smooth curves, the red lines here. All right. And the university relies on this information. This is just an example of a daily operations brief that the university officials see every single day. And one of the things that they see in this brief is, the actual cases which have been reported in New Haven, and they see a publicly available estimate of this thing called the real time or the effective reproductive number RT. But here's the sewage sludge data again. And so the university looks at these things and makes decisions about whether they should change the alarm level at the university from green to yellow to orange to red. And there's a whole set of decision rules around that, which we really don't have time to get into. So I am going to just rush to the very end here. I have a whole section here on repeat testing, which some of you might be interested in, and just jump to the summary, which is that these simple OR models, they were very helpful for the university and for the hospital and state during the first part of this outbreak. And here's a whole bunch of areas of application where they were used. Most of these things featured rapid analysis with little data. The sewage sludge example actually was the most data intensive. The approach tended to be fairly conservative, such as the crowd capping, where you basically say, okay, look, we're going to put a bound on things so we know that we'll have a probability that no infections happen, which is at least as high as what we say it is. And similarly, with the surge capacity, we wanted to make sure that we could handle a high enough level of arrivals. And similarly with repeat testing, although I wasn't able to show you that, but also that was a conservative analysis. None of this happened by itself in the sense that the results of the analyses said, okay, you built this model, so that's the answer. There was substantive experts were being consulted at every step of the way. And the university leaders, from the president, the provost on down, they were not shy about trying to understand what was going on. I had several one-on-one Zoom meetings with the president and with the provost explaining what the results were, not going into the math, but basically showing them what the results were and showing them what they implied in terms of potential decisions. So finally, here's a set of references. I think everybody's going to be able to get a copy of this if signing whatever I signed for Informs makes sense. So there's a lot of papers here which are out there, or you can just visit my website and you'll be able to see. And again, I apologize, I probably tried to pack too much in and should have left more time for some of the testing stuff. But anyway, I'll stop here. And I guess, let's see, how do I stop my screen sharing?
You keep the screen, Ed. You're able to hear me, I guess, right?
Okay, well, wait, I was able to figure it out. Okay, so if there are one or two questions, we could do that now, or if you think we're out of time, you tell me.
No, I mean, I think we can go on for a little longer. That's okay. And I think Sid just, his video showed up. Mine, not sure, somehow it's disappeared. On my side, I think you guys might be seeing it. Kushi, you may want to join as well. So these are junior faculty who are all very excited about doing healthcare research. They both help us and organize this webinar. But we have an audience here. We'd like to make sure if there are questions, they can be answered.
One thing I should
put the questions in the chat if you like.
Oh, okay. One thing I should mention is that there is a special issue of healthcare management science, and that has both the initial sewage sludge paper in it that I was talking about, the one where the epidemic model estimating R0 and stuff like that, and then it also has the repeat testing analysis in it that I didn't have a chance to talk about today. And many other papers actually on different aspects of COVID. And the title of the special issue is Management Science in the Fight Against COVID. And special thanks go to Professor Alec Morton. Some of you know from Strathclyde. He was the guest editor of that special issue.
So I don't see any questions from the audience, but I have a quick question. This is more general. So you work with the university administration. Were they in contact with the state or the city there? And some of this analysis was feeding into their decision making and their thinking?
Oh, absolutely. Absolutely.
Maybe say a few words about that. I think that'll be very, very valuable.
Well, first of all, from the very beginning, Maritza Bond, as I said, who is the director of the New Haven Health Department, met on this committee. And actually, the mayor of New Haven even came to a couple of our meetings when he was trying to decide, the extent of the lockdown and also being very, very concerned about hospitalization, of course. That was everyone's, the number one fear at the state level was that we were going to run out of hospital beds. That's what everyone was afraid of. And so the question was, do we have enough hospital capacity statewide? And so actually analysis I didn't present here, but which was helpful for, at least I'd like to think it was helpful for that, was basically I every day was updating simply a COVID projection model, and as a consequence of that, basically trying to say, here's how many how many COVID hospitalizations you should expect. I was also tracing along in real time what the current data were, so every day it would get updated. And then there were also some analyses, some very, very prominent analyses that had been conducted elsewhere, which were scaring people. For example, you may have heard at the University of Washington, there's a group called the Institute for Health Metrics, and their own model, which was really much more of a statistical model. It wasn't more of a statistical model. And they actually suggested that Connecticut was going to run out of hospital beds very, very early. But it turns out they had their inventory, their estimate for how many hospital beds there were was completely wrong. And, so things like that were problematic. But yeah, the other thing is that Albert Coe, I mentioned the person who actually twisted my arm to put me on this committee in the first place, he ended up being in charge of the state of Connecticut's public health response to the whole thing. So the person who was largely, in charge of advising the governor directly was also someone who was regularly in touch with me about these analyses. And the last thing I'll say is that the governor's right-hand person on this, his chief operations person, who was sort of like, basically the go-to person for everything that the governor wanted to do, is a former student of mine from the management school. So it turns out that in a small place, having those kinds of local connections can make a big difference.
So they end up using some of the modeling on their end as well, or was it mostly informing university in this case?
I'm sorry, Sanjay, I didn't understand.
So the question I have is, did they picked up on many of these ideas on their end as well, or, in terms of
absolutely.
Trying to leverage the methodologies and ideas? And
so first of all, in terms of the wastewater analysis, as I said, you can think of what we did locally as sort of a proof of concept. And then all of a sudden, mayors from some of the cities around the state were sort of clamoring for this because people recognized that it was very easy for people to understand that testing was giving them a biased view. Look, if there was an outbreak investigation, or all of a sudden Yale starts and they're testing students twice a week, all of a sudden the total number of tests goes way up. And so all of a sudden you're going to find more cases, but it doesn't mean that the epidemic got worse. It just means that you're looking harder. So the wastewater analysis was expanded, and that's actually a contract for the state. That's not something that Yale is doing for the entire state. It's Yale people who are doing this, who are sort of managing the whole project, but that's actually a state level contract, which is continuing. And the state really relies pretty heavily on this because they view this as an early warning signal. And also, if it turns out that there are times where the data seem to disagree, it's like all of a sudden it looks like the number of cases went way up, but it turns out that the sewage sludge actually isn't suggesting that. And then the question is, well, what happened? And in some cases, it turns out that there's nothing more complicated than there was a data backlog, and the person who literally was putting stuff into the system hadn't gotten around to it for an extra day or two. So it looked like all of a sudden there was a surge when it was nothing. It was just, so, but yes, so the state has definitely picked up on that. And the repeat testing analysis also turned out to be quite influential. There are others who have written analyses that I would argue in some ways were more like David Paltiel. You might know about his work, and he did a lot of work with the whole consortium of universities in the Boston area, with Harvard and with other universities up there, and that became very important in trying to convince the university to test as frequently as we said. And the mindset changed. It was difficult to get people to see was that you're not testing for the purpose of just asking what's the level of infection. You're testing to prevent infections. And you're basically to isolate people. Because originally the idea was the provost said, look, all we have to do, he's a quantitative person, but he's not an operations researcher. And the provost is saying, look, we can just take smaller tests, we can take random samples. And then if it turns out that we see something in one of the random samples, we can kind of go and investigate. And I would say, if you do that, you will have completely missed your chance to prevent the infections that are preventable. And the whole idea of saying, look, here's a model where you can see that the whole number of infections that, in fact, if I have a second, let me just show you one slide.
Yeah, please.
Let me see if I can find my share screen button back. Here we go. Okay. So here's the idea. Let's go up to, this picture right here, all right? This is the important picture. What happens is this lambda here is a transmission rate, and this is a time from when a person became infected. So if a person's infected at time 0, this variable A is what we call the age of infection. Now, if you're in an unmitigated outbreak and not doing anything, this is like a Poisson process. So the area under this curve, the area of lambda A, is exactly the reproductive number. It's exactly the expected number of infections that a person would transmit at the beginning of an outbreak. But what happens when you do repeat testing? Well, when you do repeat testing, a person who's been infected at time 0, at some random time t, you're going to find them. They're going to test positive, all right? And the probability distribution of what this thing is, it depends on the sensitivity of the test as a function of time from infection, but also depends on how often you're looking. Anyway, once you find the person, if you isolate them right away, then basically what you've done is taken this entire blue part of the curve and gotten rid of it. And so the reproductive number, instead of it being the area under this whole curve, is now just the red part.
Mm-hmm.
That's the idea. So basically trying to explain to the provost that really what you're trying to do is make this blue part of the curve as large as you can, as opposed to just saying, are we finding people who are infected, yes or no? And if you were only going to do something intense after a random sample told you that someone was infected, you would have missed this opportunity for several infected students. That's the point. And so on the basis of that, the university agreed. Okay, we agree with you. We're going to test twice a week. So that was a big win. And as I said, others have arrived at that conclusion using slightly different models. But basically, that's the idea. It's this change in the mindset from saying we're testing just in order to detect something versus we're testing in order to isolate, in order to prevent infections.
Yeah, and some of these binary things, right? And particularly with the mindset.
Right.
The switch has to be turned on, and so many times people are just visual, and if you just present like graph that you just presented, it goes.
Yeah,
tons of miles.
That particular picture has turned out to be extraordinarily useful, right there, because it's like it's just very interesting. I mean, as I said, when most people think about epidemic models and most people think in terms of, like, for COVID, the most common model by far is what's called SEIR, susceptible. Exposed, right. And so when you do that, then you have to say, okay, so what does testing do? And it's kind of like, okay, you find people who are either, in the exposed or in the infectious category. And it's usually people in the infectious category, because during the duration of the exposure period, there's a question as to whether or not they would test positive anyway, because it takes time for the the RNA in a person to build up until it can be detected by these tests. But nonetheless, when you just see the picture I showed you, it's obvious.
Obvious.
That model just falls right out of the renewal model. It just falls right out of it. You basically say infections are happening according to a Poisson process. The Poisson process depends upon how long people have been infected for, and we're simply going to change the transmission rate by identifying people. Boom, it's obvious. You don't need the math. You just need the picture.
I have to say this, not only Ed's a great researcher, cuts things down to the basics and really works from the fundamentals. He's just such a great communicator.
Wow.
Just, really.
Thank you.
You really are. I mean, I have a few role models in the OR community. You are one of them. I can certainly say that publicly. Really appreciate you taking the time to present.
Well, it wouldn't have happened if you hadn't invited me, so thank you very much for that.
Thank you for agreeing. And there's a couple of things in the chat, so let me just make sure that they're on the push. Yeah, I think there's some thanks from you for you. There's a thank you from David Hunt. Great stuff. And there is one from Abe Seidman.
Hi. Yeah, then one of the disadvantages in not being able to see people is I can't see who's here. But I appreciate everyone coming, and also all of these people are friends. I mean, I hope I had friends and not enemies on this talk. It looks like I had at least several friends, and if there are enemies, they've been kind enough not to identify themselves. But anyway, it's. I mean, I have to say one of the nice things about Zoom is that you are able to get together like this, and something we never did before. And I mean, I have to tell you this, just in terms of sort of feeling part of a worldwide community of operations researchers. With Zoom, I gave a talk last fall to the Nepal Operations Research Society.
My gosh.
All right. To Israel, I've given seminars in Israel. People do that, and it's not just me. I mean, everybody's doing this. You can give talks all over the world. And the thing which is nice is, again, I feel this bond inside our own profession, our own way of doing things. We're not as numerous as the economists. We're not as numerous as the statisticians. We're certainly not as numerous as the whole world of mathematics. But we do have a mindset which is different. We think about how to model operational processes and how to see the operations in things where it may not be obvious. And I have to tell you, the very first time I started working on infectious diseases, all the way back, with HIV stuff, I never took a course in epidemiology. I mean, I eventually ended up getting textbooks and teaching myself. But what made it possible for me to move very quickly was that I knew queuing theory. It suddenly became clear to me that the customers are the infections. And it became clear to me that, the service times are things like incubation times. And what's the most famous relationship in all of epidemiology? It's at least for chronic diseases, it's something called prevalence equals incidence times duration, which is exactly Little's law. So all of a sudden it was kind of like, wait a minute, I know this stuff. And I know this stuff because it's queuing. I had the same realization, perfectly honest, when I was doing terrorism-related stuff. To think of terrorism as a queuing process might seem very strange to people, but it shouldn't be strange to us because we can see the analogy. It's like, so you think about something operationally and you know enough math that you can write down the equations for whatever the process is you're studying. So I think that's special about our field, actually. I think it makes it a little bit different. There's a reason why in operations research, we're all trained in optimization. We're trained in stochastic processes and in probability. For someone who's coming from the outside and doesn't understand anything about the history of the field, and let's say it's just a mathematician, they might say, optimization and stochastic processes, that's a strange pair of topics. Why don't you focus on numerical analysis and topology? Right? But the point is, it's because optimization and stochastic processes are what you need to do in order to do operations. That's the whole point. I mean, operation.
And I'm going to have to warn you. I think Beth will need to stop this thing in a minute. So please share sentence. I think for some reason, informs. I think they're kind of back to back on some of these scheduling. So I apologize for that. But
that's okay.
I know you. I know you were flowing with a thought, and yeah, I mean, it's queuing and optimization and. Some of the decision analysis stuff is at such a core. And once you get past that, understand it, it's just
right.
Really thank you for such a wonderful presentation and all the Q&A. Very inspiring. Very inspiring. Appreciate it.
Thank you. And thank you. I appreciate that to all of you who have stayed with us to the bitter end, as it were. But I do hope to see many of you again, either online or in person. I see Beth is trying to get rid of us because I guess they have. So Beth, we hear you. We see you. Go do what you have to do.
Well, hopefully we'll see you over at the national meeting.
All right. Take care, everybody. Have a wonderful weekend.